Okay, and any questions, just let us know. So you probably have seen this before. This just shows you a rough breakdown of the question allocation. And you can see that your clinical skills is actually a majority of your marks, followed by anatomy. So don't underestimate it. Okay, so we'll start with RESP. So what we've done is that for each system, we've put up your systems review questions. We're not going to go over them. You really just need to make sure you memorise them all and ask them all if you ever get an OSCE. So we'll start with this. Can I get rid of this? You can't see that. That's all right. Okay, so Hannah is an 18-year-old who presented to her GP, 3-month history of shortness of breath and wheezing, which occurs mainly while playing netball and relieved upon rest. The wheezing is worse at night and she's a current smoker. Which of the conditions is she most likely to have apart from her primary condition? So can someone shout out what her primary condition would be? Asthma? Yeah. So why is it asthma? Someone want to have a go? Yep. Yeah, I don't know. Oh, I can. Yeah, thank you. Okay, does someone want to have a go? Why do you think it's asthma? Yeah, the wheeze. Anything else? Do you want to shout it out, someone?
Anything else apart from the wheeze?
Young age.
Yep.
Yeah.
And this worse at night is quite typical of asthma as well as the smoking. So what do you think the answer is? Anyone know which one of these is more associated with asthma? All right, hands up for A, B, C, D. Yeah, good.
What else is associated with them? Eczema, asthma.
Okay, very good.
Rhinitis.
Okay, so moving on now to tracheal deviation. It's likely that you get some questions that give you a collection of signs and you have to be able to figure out what condition it is. So just get you to shout out whether each of these is you have tracheal deviation towards or away from the disease side. So tension pneumothorax. Away, good. Atelectasis. Yep, a large mass. Good. Pleural effusion. And fibrosis. Hands up for towards. Hands up for away. Okay, no idea. Yeah, it's towards. So can anyone explain how you know which way the trachea will deviate? Anyone? No? So essentially, the trachea moves towards the side of less pressure. So a mass will push the trachea away from it, and a tension pneumothorax as well if you increase pressure on that side. And if you have decreased pressure on one side, it will move towards it as well. Okay, moving on to percussion. You just shout out a condition. Okay, so what condition has hyperresonant percussion?
Yep, you got it. There. One of you guys.
Yeah, good. Stony dull percussion. Anyone? Stony dull. Yeah, good. Pleural effusion for stony dull. What about a dull percussion?
Come on, guys. One of you know.
Yes, I heard pneumonia. So consolidation and resonant. Yeah, good. A normal lung. So hyperresonant, you're thinking about increased air. So that happens with the pneumothorax. Stony dull is a pleural effusion, so fluid. You're Dull is consolidation, so infective consolidation, or also just a solid organ. So don't forget that your heart and liver will also be dull, and you're expecting a normal, healthy lung to be resonant. Okay. Have a read of this. Which of the following describes normal breath sounds? So just have a read of those options. All right, hands up for A, B, C, D, E, and no idea? Yeah, okay. I heard some people put their hands up for C. Does someone want to, what do we call normal breath sounds? Yep, vesicular. I'm hearing people whisper that. So C is actually describing vesicular breath sounds. So they are louder and longer on inspiration, and they have no gap between the inspiratory and expiratory sounds. So abnormal breath sounds can be described as bronchial. So we hear this blowing quality. It's a bit hard to imagine if you haven't heard them before, but you can also YouTube breath sounds if you would like to.
A really easy way is put your stethoscope on your trachea and you'll hear bronchial sounds, but you shouldn't be hearing that over the lung itself.
Yeah. You can have a wheeze. So this is a whistling that you hear, which is generally louder on expiration. Crackles are interrupted noises and non-musical. And you might have heard them described as like Velcro or hair rubbing together as well. And anything stridal you can hear over the trachea. If you have some kind of blockage, you can hear it only on inspiration for that. Okay, resonance. So we know that, how do you assess for resonance in the respiratory exam? Anyone? What do you do before, like, so you've listened to your breath sounds, how do you assess the resonance? So yeah, 99s, and you can also feel for your fremitus as well, similar idea. So true or false for each of these? 99s are muffled over areas of consolidation. Hands up for true. Hands up for false. Okay, no idea. So if you listen to your own lungs and you say 99, they should be muffled. And what happens is when you have increased consolidation in the lungs, the sound actually travels better and you can hear them more clearly. Okay, E's, so you get people to say E when you're listening as well. True or false, E's sound like A over areas of consolidation. Hands up for true. Hands up for false. No one? Does anyone want to have a guess? You've got like 50-50 chance. Yeah, true. Same thing, the sound is distorted if you have consolidation. Okay, tactile fremitus is increased over areas of consolidation. Hands up for true. Hands up for false. Okay, you have to put your hand up for one. So hands up for true. Yeah, hands up for false. Okay, good. So you can do it now. If you put your hand on your back, right, and say 99, can you feel the vibration on your hand? You shouldn't be able to feel it very well. And if you have consolidation, it's much more obvious. Again, because sound travels better over areas of consolidation. Okay, whispered pectoriloquy is normal. So after you've gotten your patient to say 99, you then get them to whisper 99. So do you expect to hear the whisper? Yes? Hands up for yes? Hands up for no? Yeah, good. So you wouldn't expect, if there's no consolidation, you shouldn't hear a whispered 99. Does that make sense? Increased consolidation, increased sound travel, better heard on auscultation. Is everyone happy with that? Okay, so I won't go into too much detail with this. You need to be able to interpret a normal chest X-ray. Very likely that you get an OSCE on this as well. It's fair game. So there's plenty of different ways to interpret it as long as you have a systematic approach. So we were taught A, B, C, D, E, F, G. Making sure that you always start with your general introduction. You actually check that you have the right X-ray, the right patient, whether it's AP or PA. And if you want to get some extra marks, you can talk about the adequacy of the X-ray as well. So I think you've got these slides, you can read over that. Just being really clear that you know what each of your structures are, what your borders mean, and just how to systematically go through and check that it is normal. Does anyone have any questions on the chest X-ray? No? Okay. Sorry, I have to move pretty quick through this. So on to GIT now. So one of the most important symptoms is abdominal pain. You'll do more of this next year, actually coming up with a list of differentials for the cause of the pain based on where it is in the abdomen. But it doesn't hurt if you do it now. Like, how many times have you heard, you know, starts in the umbilicus and moves to the side, and you know that it's appendicitis? So just keeping that in mind. And if you're doing an OSCE and someone says, yes, I have abdominal pain, you need to actually go into more detail about that. So you need to work out whether it was an acute onset, chronic onset, whether it's changing over time, moving throughout the abdomen. And it's really important that you ask whether it's colicky, so whether it's coming and going or it's a constant pain. And alleviating and aggravating factors can give you a lot of information for abdominal pain. So a classic example is renal colic from kidney stones. A patient will literally be rolling around on the bed, unable to sit still. Whereas someone with appendicitis, they will be lying absolutely still, not moving. So it's important to ask whether they prefer a certain position. Any questions on that? Okay. So now thinking about some specific signs that may come up in the abdominal exam. So, tenderness on inspiration at the right costal margin. Can someone give me the name of that sign? Yeah, great. Does anyone know what causes Murphy's sign? Cholecystitis, good. So gallbladder inflammation. So it's important that when you're doing your exam, you make an effort to stop in that point, be really clear to your examiner, breathe in, breathe out, and show them that you are assessing for Murphy's sign. Tenderness, 1/3 of the distance between the aces and the umbilicus. Yeah? I'm hearing it somewhere. Yeah, McBurney's point. Good. And what causes that sign? Yeah, appendicitis. Very good. Pain in the right iliac fossa when you press on the left side. Yeah, I mean, can someone say it a bit louder? They'll rub things. Good. And the cause? Appendicitis as well. Okay, prominent engorged and distended veins on the abdominal wall. Yeah, caput medusa. And what causes this? Very good, portal hypertension. Does anyone know where else you might get signs of portal hypertension? Yeah, esophagus, and where else? Very good. Discolorate, the last two kind of go together. Discoloration of the flanks. Yeah. Can someone shout it out louder? Grey Turners. And discoloration of the umbilicus. Cullen's good. And what are they both a sign of? What are they a sign of?
Yeah.
Can you hear it? We can only hear whispers, so someone shout it out.
Don't be afraid if you get it wrong. There's nothing wrong with being wrong. So no one's going to embarrass you. It's fine. And you'll learn more if you get it wrong.
So what are they a sign of? Yeah, thank you. Pancreatitis. Very good. Okay, so when we did our OSCEs, we actually had a station that was perform a focused abdominal exam, explain ascites to the patient, and demonstrate percussion for shifting dullness. It's not necessarily something you might spend a lot of time on, so it's important that you do know every part of the examination because they can ask you to focus in on one specific point. So understanding that ascites is a collection of peritoneal fluid, and initially in early ascites you get collection in the flanks just because of gravity, and as it progresses you get the distended abdomen and it moves around the entire space. So when you percuss, you need to have your fingers pointing down towards the midline, starting in the middle, and you percuss outwards. So you percuss away from you. Okay, so remember you're always standing on the right-hand side of the patient. And if you get to a point of dullness, that means you've hit fluid, and you need to stop and mark that point with your finger. Get the patient to roll towards you, and you wait. In an OSCE, you're probably not going to wait a whole minute, but you'd say, I would like to wait a whole minute. And this allows the fluid to move to the other side. So you've asked them to roll onto their right side, so it's moved. You percuss on the same point. If it's still dull, then the fluid hasn't moved, but if it's now resonant, the fluid has shifted to the other side, and you can say shifting dullness is present. Does that make sense?
And if you really want to be smart, you point in the other area and then actually measure the distance and say there's a shifting dullness of 5 centimeters, for example. But not expected in second year, I think.
It just goes to show, don't discount any one part of the exam because they can just ask you to focus on that, or skip parts of the exam, go straight to one bit.
I think there's a typo in one of the
probably
slides, or the last one. If the area is now resonant, I think.
Yeah, thanks. So remember, fluid is dull and air is resonant. Thank you. Okay, which of the following is true regarding liver disease? I'll let you have a read. Okay. Hands up for A. Hands up for B. Hands up for C. Hands up for D. Okay, so we'll go through them. So hepatomegaly is enlarged liver. So we say that a normal liver should be under 13 centimeters. So if you have an enlarged liver, it should be over 13 centimeters. And technically, you're supposed to actually measure with a tape measure when you percuss the liver in an OSCE. Resonant on percussion, it's a solid organ, so it should be dull. C, gynecomastia suggests alcoholic cirrhosis as the cause. So what is gynecomastia? Yep, enlargement of breast tissue. So that's the answer. We'll just go on to D first. So when you're assessing for hepatomegaly, remember you start from the right lower side and you advance upwards towards the liver, and you want to keep your hand pressed on the abdomen during inspiration, because that is when the liver will move and hit your hand. And when they're expiring, that's when you advance your hand up. Does that make sense? Okay, so yeah, so when you have cirrhosis, liver disease, so estrogen is broken down in the liver, and when you have liver disease, the liver loses its function. So you actually get increased estrogen throughout the body, and that's why you get signs such as gynecomastia, what else do you get? Loss of hair, everything like that, because you have increased circulating estrogen. And more likely alcoholic cirrhosis there. Any questions with that? Okay. And on to endo. So endocrine history is a real pain if you get it. It's very vague. I think the best way to do it is just go head to toe, know all your signs. There's not really an easy way out of it unless you take a thyroid history, take a diabetes history. Okay. So you need to be able to recognize clusters of signs and attribute a condition to those signs. So what is the condition for weight gain, seizures, and sweating? What does that make you think of? Someone shout it out. Any ideas? There's not many conditions that will give you a seizure, if severe enough. Okay, no one has any idea? Okay, so we're looking at hypoglycemia. Okay, so if someone's hypoglycemic, they will put on weight, very severe, they will have seizures and very sweaty. Okay, the next one might be a bit easier. Moon-like facies, buffalo hump, truncal obesity, purple striae, myopathy and bruising. Cushing's, very good. Cold intolerance, eyelid edema, hoarse voice, lethargy, constipation, coarse skin, hyperkeratonemia. Yep, hypothyroid. Polyuria, polydipsia, thirst, blurred vision, weakness, infection. Diabetes, good. Weight gain, fatigue, increased sweating, heat intolerance, enlarging hands and feet, coarse facial features, voice changes, decreased libido and impotence. Yeah, good, acromegaly. Heat intolerance, agitation, weight loss, polyphagia, palpitations, sweating, diarrhea, amenorrhea, muscle weakness, and dyspnea. Hyperthyroid, very good. Any questions about any of those? Okay, so it's likely that you get a question on the dexamethasone suppression test, which can be quite confusing. So you need to be able to differentiate between Cushing's disease and Cushing's syndrome. Does anyone know the difference? Does someone want to have a go? Can you hear lots of whispering? No one? Okay. So Cushing's syndrome is just high cortisol in the body, which causes those collection of signs I showed you before. Cushing's disease is specifically a tumour on the pituitary that's increasing ACTH production. Does that make sense? So if it's anywhere other than the pituitary, it's a syndrome. So, and remembering your axis here, the anterior pituitary releases ACTH, which stimulates cortisol production from the adrenal cortex. So and then we have negative feedback. So just keeping that in mind, it helps you make sense of this. So in a normal person, I should say first, dexamethasone is a steroid that acts in a similar way to cortisol. Okay, so in a normal person, you expect normal cortisol, normal ACTH, everything's working okay. If you give the dexamethasone, it's essentially like you're giving cortisol, you're going to expect suppression of this feedback system. Does that make sense? Okay, so in Cushing's disease, so we have increased ACTH, and so we're going to have increased cortisol as well. If we give low dose dexamethasone, so we're giving more cortisol, we see no change. But if we give a high dose of the dexamethasone, we see some suppression. And this is because in Cushing's disease, you still do retain some level of feedback. In contrast, in Cushing's syndrome, remember this is cortisol from another source, so we have high cortisol, and that's feeding back onto the ACTH. So adding more of that cortisol isn't going to make any difference. There will be no suppression. Does that make sense? So the main difference is in these two boxes here. Okay. So onto pituitary tumours. So depending on the type of tumour, they can hypersecrete hormones, or you can have undersecretion. And just something that's come up a few times in the past is there's actually, if it's a hyposecretion, there's an order that the hormones get lost in, and that's because you lose the ones, like the last ones to go are the ones most important for survival. So first you get loss of growth hormone, prolactin, and then it moves on from there. So the first signs may be signs of low growth hormone and low prolactin. So very classically is bitemporal hemianopia. Can someone tell me why a pituitary tumor would cause that? Yeah, I'm hearing optic chiasm. So if you look at this, where the pituitary is, it presses right in the middle of that chiasm there. And just based on the structure, you can see how close cranial nerves 3, 4, and 6 are. So if it gets large enough and presses on those, you get changes in those cranial nerves first. Okay. On to diabetes. Again, remembering diabetes history, diabetes exam, all very fair for an OSCE. And just remembering a few of the technical things. For actually diagnosing diabetes, you have to satisfy some criteria. So if the patient is symptomatic and you get one abnormal test result, you can make a diagnosis. If they are asymptomatic, you need 2 separate results on different days to make a diagnosis. And most people, especially with type 2 diabetes, won't present with any symptoms until they start developing complications. So it'll just be on a routine checkup. Making sure, again, for an OSCE, explaining blood sugar levels, even taking them and explaining it, you need to know your levels. Just remember 7-11 for that. So random, anything over 11, and fasting needs to be 7. And you've got your HbA1c. Can someone tell me what that tells us? Anyone? Yeah, good. So it actually gives you a measure of your longer-term control of your blood sugar. So it's, especially once you've been diagnosed with diabetes, it's very important. A lot of the time patients come into hospital saying, I swear I take my insulin, and you check their HbA1c, it's really high, and you know they haven't been controlling it well. Okay, and then complications, so you have your macro and microvascular. So you should be able to tell me these. Can someone shout out, there's 3 of each. What are the macrovascular complications of diabetes? Anyone? What's the most common cause of death in a diabetic? I'm hearing heart attack. Yep, so heart attack is one. Can you think of something else related to a heart attack? Another organ? Yep, stroke and something else. Yep, peripheral vascular disease, good. So you're thinking peripheral vessels, heart and brain, and then your microvascular, what are they? Good. So retinopathy, neuropathy, and nephropathy. Very good. Okay, any questions on that?
All right, so when you go into renal, can anyone hear me at the back? All good? How's second year going? Amazing. Hands up for amazing. Good. Shit house. Something in between. All right. So renal's pretty straightforward. It's not very, very high yield, but these are, I guess, the system review questions you'll need to know. Urine dipstick is pretty high yield, especially in OSCE. So you'll need to know all the different, I guess, aspects of a urine dipstick. So specific gravity, essentially how concentrated is your urine. pH, so if it's acidic, they're in DKA, they're fasting, various other reasons. An alkaline would be a UTI, or if they're taking urinary alkalizers, so if they have gout, for stones, for example, we give them alkalinizers so we can get rid of the stones. Leukocytes, pretty straightforward, so infection or inflammation. Nitrites, so if there's nitrites, that can be a sign of a UTI. Anyone know why? Anyone? I'll start picking people from the crowd. Yeah, good. Protein, so if you're exercising a lot, for example, or if you have, say, nephritic or nephrotic syndrome, which one out of the two has the most protein, nephritic or nephrotic? Yeah. And what does nephrotic have, doesn't have that nephritic has? Yeah. Glucose, so diabetes, ketones, DKA, urobilinogen, hemolytic jaundice, bilirubin obstructive jaundice. and blood, obviously erythrocytes and hemoglobin. You doing heme?
Yeah.
Oh, I doing it? I had no idea.
Like as you're doing it.
No, that's fine. So red blood cells. This is system review, left to memorize it, I guess. No one can really teach you it. So lymph nodes, your epitrochlea, in your epicondyle, medial epicondyle in the cubital fossa. Your axillary lymph nodes, cervical, supraclavicular. Anyone not know where these are? Hands up. Yes, no, maybe. So if you do feel a lymph node, you probably won't endoscopy. You don't have any, I guess, pathological symptoms. But if you do, you'd mention the site size, hard, soft, or rubbery. What does hard mean? Usually, it's a buzzword. Cancer, yeah. Rubbery. Usually lymphoma. Rubbery. Tenderness usually would be infection or inflammation. If it's fixed, and if there's overlying skin, if there's inflammation or tethering, for example. So the spleen, usually not palpable. I think if it's over 3 times the size, becomes palpable. And you'd move from the right iliac fossa to the left hypochondrium. Get them to inspire and expire as you move up. And these are, I guess, some of the, tests or,
It's just where you want to percuss in your OSCE and make a point of finding the right position and getting them to inspire and expire.
So anemia is very, very high yield, especially in second year, third year as well, fourth year, throughout your whole career. You'll need to know this to death. So the way we usually do it is if their HB is low, they're defined as anemic. And then you look at the MCV, so the mean corpuscular volume, and that will tell you essentially how big the cell is. So if it's small, it's called microcytic. If it's normal, normocytic, and then increase, obviously macrocytic. If it's microcytic, usually there's a lot of causes, but the two most important would be iron deficiency and thalassemia. So if you differentiate that, obviously look at the ferritin. So ferritin is the, I guess, molecule that stores iron. So if it's low, then you're iron deficient. It makes sense. If your iron's low, you don't want to store more iron, so it'd be low. And if it's normal, you probably have thalassemia. Your normocytic, you look at the reticulocyte count. So that's essentially the precursor to the red blood cell. So if it's increased, you're either hemolyzing your cells or you're losing blood. Does anyone know why that would be increased? Tell me. Yeah, so your body's working in overdrive to try to replenish the cells that you're losing. And if it's not increased, something's wrong with you. So you can't actually make blood cells. So you'd have low reticulocytes. And that's in leukemia, for example. Macrocytic, you need to know these, folate and B12, very high yield. If you're going to walk away with anything, know this table or this chart. Cardio. System reviews, again, have a look at it. Very important. So, quick question. So, which of the following is tender on the hands? Janeway lesions, xanthomatas, splinter hemorrhages, Osler nodes, telangiectasias. All right. Hands up for A. B. C. D. Yep. E. No. So Janeway lesions, splinter nodes, splinter hemorrhages, and Osler nodes are signs of what? Yep. Xanthomata. Yep. And telangiectasias. It's very non-specific. Many conditions would cause it. So which of the following can you best describe from the radial pulse? There's more than one correct answer. A, B, C, D, E, or F. Hands up for A. So only A. B, C, D, E, or F? So that's the answer. So your rate, you could tell obviously if it's going fast, slow, the rhythm, if it's regular or irregular, and then your radiofemoral delay as well.
So where can you assess character and volume from? Yeah, good.
All right. So what does a parasternal thrust under your palm indicate? A, B, C, or D? What do you guys reckon? Yeah. What do you think? What's that? A. All right. Anyone else? Next to it? No? No? Well, yeah, obviously. So your right heart, I guess, when it enlarges, you'll feel it, I guess. We call it heaves, thrusts, impulses. You don't really feel the left ventricle when it enlarges. A thrill is a palpable murmur. So if you have, say, aortic stenosis, things like that, you might feel it. So that's like a really severe murmur. Infective endocarditis, usually you won't feel on the precordium. So right versus left heart failure. This is very high yield. You need to know this, not just for now, for your life. What are some signs of right heart failure? Ankle swelling, yeah, definitely. Anything else? Yeah. Anything else? So essentially what happens is when your right heart fails, you get a backflow. So you're going to get edema. You might get ascites, for example, hepatomegaly, raised JVP. Those are, I guess, the more high yield. Now your left heart, what would happen? Pulmonary edema, yeah. So that, I guess, what would happen? Well, what signs would you get? Patient, he's not going to come in saying, I have pulmonary edema. But yeah, you'll be short of breath. So that's, I guess, a really good diagram. Sometimes they might present with both. So it's not really one or the other. Usually it presents as one or the other, then progresses to both. So edema, how do we kind of categorize edema? Just one or two ways. Is that? Yeah, good. Pitting or non-pitting? So your pitting would be your heart failure, liver cirrhosis. Anyone know why you get edema, liver cirrhosis? Ascites. Yeah, it's okay. So anyone else? Any other takers? Yeah. Anyone? Do you know? Who you guess? All right. Next one. Yeah, correct. So your liver loses its synthetic function. So if it's not making albumin, your oncotic pressure would decrease, and so you get a shift in the fluid according to Starling's law. Venous abnormalities, renal. So why would you get edema and nephrotic syndrome? Come on, guys, take a guess. You'll get this next year. You'll get absolutely roasted in your bedsides. They'll ask you questions, and they will put you on the spot. So it's really good to learn it now. Nothing wrong with shouting out an answer.
Proteins keep the fluids inside the blood vessels, so if they're gone, then the fluids just flow out.
Yeah, so it's kind of the same kind of way of thinking as liver cirrhosis. Instead of not making more, you're losing more. And DVT as well. Non-pitting, your hypothyroidism and your lymphedema.
All right, so onto MSK. Like, guaranteed you get one of the exams in your OSCE, like 100%. So make sure you can do them all. Also, something that we ran into trouble last year, depending on who you practice with, make sure if you're like a really small person. Make sure you practice with someone bigger than you. Trying to do, shoulder movements on someone who's double your height is actually really hard. Trying to lift a leg that's really heavy is also hard.
We had a 120 kilo bloke for a hip exam, and one of my colleagues like this small. So yeah.
Be wary. Yeah.
Hit the gym for a bit.
All right. It's actually something to think about as well. You get really used to practicing on young, healthy people, and in your OSCEs, even if I remember in a cardio exam getting quite an old man, and I was like, where are his ribs? Like, where's his sternum? It's so just be aware.
One more really quick thing as well. When you're practicing with your colleagues, you get into the routine of preempting the movement. So try act like a normal person that you don't know what the hell's going on. So don't ever say, "Oh, can you flex or extend your hip?" They won't even know what that is. So try show them the movement, and then they'll do it afterwards.
Especially with the neuro exam.
And neuro as well.
Yeah. There's lots of positions you have to get people into, and you'll find as you're if you're practicing with someone, they'll be doing this as you do it exactly for you. So practice with people who have no idea what's going on. Okay, so each of these, let me know if they're true or false. So stiffness is worse in the morning for osteoarthritis. Hands up for true. Hands up for false. Okay, so what's the other type of arthritis? That's really important. Rheumatoid. So osteoarthritis generally so rheumatoid is worse in the morning. Okay. Herbert's nodes are found on the distal phalanx. Hands up for true and false. So we remember this HD and BP. Okay, so Herbert's distal and Bouchard's proximal. Okay, HD, BP. Compression of the radial nerve causes carpal tunnel. True? False? Good. Which nerve? Good. How do you test for carpal tunnel? Yeah, see people doing this. And what's the other one you can do? Yeah. Good, tapping. Okay, pain over the lateral epicondyle when extending the wrist against resistance indicates lateral epicondylitis. So it's a bit wordy. True? Hands up for true. Hands up for false. Yep, so that one's true. So extending the wrist against resistance, pain on the lateral side, lateral epicondylitis. Medial epicondylitis, how do you test for that? Yeah, flexing your fingers, good. Varus stress test assesses the medial collateral ligament. True, hands up. False, hands up. Good. So a varus stress test is applying pressure on the lateral collateral ligament, and a valgus stress test is for the medial collateral ligament. Any questions about those?
All right. Neuro. Who likes neuro? Who hates neuro? Everyone hates neuro. No? All right. So these are, I guess, system review questions you should consider. We had a neuro history last year in OSCEs. It was a weird history because she was crying during the history and stuff. She said she had a bit of depression. There was a bit of everyone got thrown off. So just keep your game face on. Make sure you get through the system review questions. Cranial nerves. Very high yield. You should know this. Deviation of the tongue to the left side. Which cranial nerve would have a lesion? All right. Who's going to answer? 3, 2, 1. Everyone's whispering it out, not saying it. Hypoglossal. Ptosis, down and out, dilated pupil. Yep. Oculomotor. Down and out is pretty like buzzwordy, so probably know that. Absent corneal reflex. Which one, sorry? So this one's a bit of a, is like kind of two right answers. Your afferent pathway would be your trigeminal nerve, so that's your sensory. And then your efferent would be your facial nerve, because that controls your ocularis muscles. So it would be trigeminal or facial. Weakness of down and out movements of the eye. Guy in the blue talking. Do you have an answer? Yep, good. Inability to puff out cheeks. Everyone's like looking away. Facial. Diplopia, failure of lateral movement of the eye. Abducens, yeah, good. And deviation of the uvula to the right side. Glossopharyngeal, yeah. Do you have a question? No? So really important, deviation of tongue to the left side. So tongue deviates towards the affected side, whereas in the uvula, it deviates to the normal side. Okay? So upper and lower motor neuron disease. If you're gonna get anything away from neuro, just know the difference between these upper and lower and your cranial nerves. Very important. For clinical practice mainly, you'll learn a lot of, I guess, minutiae in first and second year. You probably will never even need to know later on. But these are kind of the things that you really need to get used to. So an upper motor neuron impairment produces which of the following changes of muscle tone? Plasticity, spasticity, cogwheel rigidity, or myoclonia? Spasticity. Anyone know why you'd become, I guess, have spastic muscles? Why wouldn't it be flaccid? Tied up. So your upper motor neurons, I guess, send out inhibitory signals towards your lower motor neurons. So if you lose them, you lose your inhibition. So you're essentially disinhibited, so you're activated, I guess. Cogwheel rigidity is usually signs of Parkinsonism. So muscle wasting develops in the long term in which of the following? Shout out the answer. A, B? A or B? A? Usually not. It's your lower motor neurons that would cause muscle wasting. And it's always in the long term. So someone with a lesion, say, in the peripheral nerves, they won't have any atrophy until later on. And the reason why you get the atrophy is, guys, no talking, please. So the reason why is because your lower motor neurons release trophic factors. So if you lose the lower motor neurons, you'd lose, I guess, the bulk. So it's called denervation atrophy. So features of the two, very important. You'll get might get an MCQ, differentiating the two. So site of the lesion, upper motor neurons, where would they be? Brain, yeah. Anywhere else? Spinal cord, anywhere else? Well, like, say the brain, it's pretty brain stem, yeah. So cerebral cortex, cerebellum, brain stem, spinal cord. And then lower motor neurons? What's that? Peripheral nerves, yeah, yeah. So you can get the anterior cell as well. Even the neuromuscular junction is technically, but it's pretty vague in that sense. Muscle weakness. Would you get muscle weakness in upper motor neuron Cs? Hell yeah. Yes. In lower motor neuron? Yes. So it's a really non-specific sign. So you got to kind of differentiate more. Muscle tone, we went into this. Upper motor neuron, spastic, lower motor neuron, flaccid. Fasciculations, would you get it in upper motor neuron? No, correct. And then would you get it in lower motor neuron? Yeah, saying yeah. How do you try to elicit fasciculations if you can't see it overtly? Flick, yeah, good. Your deep tendon reflexes, would they be absent, increased in upper motor neuron? Increased, yeah, good. And then lower motor neuron, yeah. And your plantar reflex. So what would you get in an upper motor neuron? Fanning out, you get upgoing plantar. So it's called, you know what the sign is called? Babinski, yeah. Babinski sign. So it's positive. And then if it goes down, it would be Babinski negative. All right. Nerve lesions. So probably not really, really high yield in near 2A, but you might get it. So if you get a complete transection, so you get a samurai sword, you cut the whole spinal cord, you get obviously combined loss from everything below. If you cut, I guess, the right side of the thoracic cord, you'll get a kind of a weird pattern. You'll get loss of vibration and position on the right side, and then you'd get loss of pain and temperature usually on the left side. Anyone know why? Anyone know what this is called? It's got a condition. It's a name, I guess. Yeah. Brown-Séquard syndrome. So essentially why is because you get decussation. So it crosses over the fibers for pain and temperature. So it crosses over to the other side and then traverses and goes up, whereas the vibration and position remain on the same side and go up. Cauda equina, they say saddle losses. What's it called? Like some buzzword. Saddle anesthesia. So it's an emergency. If you get an S1 radiculopathy, so your nerve S1, so you lose sensation in kind of one region. And if it's a peripheral neuropathy, you'll get glove and stocking distribution usually. So diabetes, for example, is a really good one. Dysphagia. So there's two types, receptive and expressive. So what would be the difference between, I guess it's already here. Yeah, it's already here. So which area would be receptive? Wernicke's, yeah. And then your expressive? Broca's, yeah. So with her eyes closed, the GP has asked a 65-year-old patient, Madonna King, to hold out both her extended arms up with the palms facing upwards. The GP noted that the presence of an upward drift with pronation of Madonna's left arm, which is the most likely cause of Madonna's examination findings. So hands up for E, D, C, B, or A? Yep. Right. So I'll try this as fast as possible. This is probably, we had this on an OSCE last year. We had a patient feeling quite hot. So you probably will need to know this. I haven't put in a lot of undifferentiated ones, usually the higher yield ones. So someone's going to come in fatigued and tired. You have no idea what system it is, so you can't just rattle off a systems review. You got to kind of think about what conditions would cause this, and this is all third year, but you might get one probably on an OSCE. So endocrine, usually look at hypothyroidism or diabetes. Look at hematology, so there could be anemic I guess you just probably learn these. Don't get bogged down on too much detail. Systemic, so if there's any signs of malignancy, cardiovascular, heart failure, psychiatric, depression, or drugs that are on beta blockers, and that's a lot of money there. What was I going to say? So you probably won't have time to go through all of this. So usually in the STEM, they'll say, there's a 20-year-old patient. So obviously you're not going to talk about, menopause, obviously. They're probably not going to be on beta blockers. They might have depression, for example. They could have anemia, and there could be hypothyroidism, hypothyroid. So kind of look at the STEM, look at the patient itself, and then try find out or think about what could be your differentials. And
they should say take 3 relevant systems or 2 relevant systems. So that just gives you a bit of an idea of what's expected as well.
If it's an old patient, 7-year-old male, previous heart attacks, you're going to think heart failure, for example. Weight loss, another high yield one. So endocrine, hyperthyroidism, diabetes, usually type 1, GIT, so they're not able to absorb, so colon cancer, cerebral bowel disease, celiac, again, malignancy, and depression as well, psychiatric issues, or anorexia or stress. Again, you can have the patient as well. So they're going to tell you 25-year-old, 30-year-old, they're going to think hypothyroidism, maybe depression, maybe IBD or celiac, for example. Probably not going to have colon cancer. Feeling hot. So we had this in the OSCE. I remember it was an old lady. So a lot of people chose, menopause, hyperthyroidism, could have infection, systemic, so malignancies, or certain drugs. So for infection, it's really hard to kind of ask about infection. You kind of say, oh, do you have an infection? They would have no idea. So you're probably just going to say, do you have any tummy pain, any cough, do you have any neck stiffness? It's kind of like a quick survey of all the, organs that could be infected. So that finishes it up for us today. Does anyone have any questions? No? Is anyone at Eastern next year? Yeah, if you have any questions or anything about it, feel free to come down. All the best for OSCEs and next year.
Thanks so much, guys. If you want any quick Ukraine, feel free to grab the boxes. Oh, good. Hey, man. Good to see you. Did you drive down today?
No.
Last night?
Fuck no. I drove down on Friday.
Fair.
Actually, no, I didn't drive down. I flew down.
Oh, you flew down. Have you got stuff on a USB or is it just a live?
I've got on my USB.
Thanks, guys.
I got it on USB.
Perfect. How's everything up in Melbourne?
Well, I volunteered to do this. So evidently, things are pretty fun.
Fair enough. Does it come up?
Let's see. Do I need to wear a mic or something?
You can if you want to. That it works.
Oh, cool.
Nice. So free to start whenever you want. It's already recording.
Oh, cool. I'll just wait maybe 5 minutes.
Yeah, all good. Have you got presenter notes?
Presenter notes?
Oh,
no.
No? Okay. Then you'll be all good. We weren't able to get them up, so whenever you're ready, just But yeah, give him like a minute or two.
Yeah. Okay, I think we might make a start, guys. Yeah, so, hi guys. Yeah, it's me again. Yeah, I also grew my hair out, and yeah, it looks pretty nice, thank you. So, today we're going to go through all of the upper limb. I timed myself on this yesterday, and it was about like half an hour, so hopefully it'll finish early. So we're just going to take it by compartments, talk a bit about nerves at the start. There's not an awful lot to talk about. It's pretty easy, hopefully by now. Here are the references that I used. You can't actually access Anatomia anymore, I've noticed, which kind of sucks. More and Dowie's kind of sucks, and Teach Me Anatomy is basically the only one that you should be using. Yeah. That being said, people tend to do pretty well for anatomy. It's about 75%. I think last year in the VIA, the average was about 70% overall. So yeah, 75 is pretty good. People tend to do pretty well. Don't ignore your theme 1 and 2 stuff like me. Like, just don't do that. So we'll start off with basically all of dermatomes, myotomes, and just any peripheral nerves. I've got a bunch of questions at the start, just like last time. So we'll see how we go. If you think you know the answer, put your hand up. Don't be a wanker and call out the answer, okay? Great, let's move on. So a man stabbed in the back following a bar fight, knife lodged between C5 and 6 on the right side of the spine and damaged the spinal nerve emerging. What deficits do you anticipate? I can see people doing like the... It's good, I'm proud of you. Yes. D. Do we agree with D? Do we not even know what the answer is? The answer is actually D. Well done. So between C5 and C6, what spinal nerve comes out? C5 or C6? C6. Okay, and that's because in the cervical spine, the spinal nerves come out on top of their respective vertebra. They only come out at the bottom from C7 onwards because there's an 8th cervical nerve, but there's no 8th cervical vertebra, so it pushes everything to the bottom. So knowing that C6 has been damaged, none of the others are consistent with damage to C6. The only one that's consistent with that is shoulder adduction, which needs C6, 7, and 8. So a 65-year-old lady presents to your clinic following mastectomy for a checkup. You notice that when she pushes her arms against the wall, that her left scapula juts out. Which nerve has been damaged? Yes. D. Yeah, it's the long thoracic nerve. So what's being described in this question is winged scapula, and it's a sign that's usually associated with paralysis of serratus anterior, which holds your scapula against the thoracic wall. And serratus anterior is innervated by the long thoracic nerve. The long thoracic nerve along the thoracodorsal nerve are like 2 nerves that usually get threatened, or there's like a risk of damaging them in a mastectomy. You don't have to know that, I don't think. In terms of dermatomes, the only time you'll really ever need to use it is during your OSCE. And the easiest way to remember dermatomes for your OSCE is just to remember certain anatomical landmarks that are associated with each dermatome. So basically, starting from the top, you've got C5, and C5, you just remember it as your lateral epicondyle. C6 is your thumb. C7 is your middle finger. C8 is your pinky finger, and then T1 is your medial epicondyle. So if you can like imagine your arm, you've got C5, 6, 7, 8, and then T1. And anytime you've got a test sensation along the dermatomes, you just basically remember these anatomical landmarks and just use it for every single sensation. Like, doesn't matter if it's pain or light touch or like temperature or anything like that. You just always use these landmarks and you'll get it right every single time. Don't have to remember the specific regions of skin that are innervated. You don't have time to remember that. Myotomes are a bit harder. They're a bit harder because they're not exactly intuitive, but there's sort of a general trend that goes with the myotomes. So starting from the top with the shoulder, basically everything in the shoulder is C5 and C6. Except for adduction, adduction, which is 6, 7, and 8, like we talked about. With elbow flexion, it's C5 and C6, and elbow extension, C7 and 8. And what you'll notice is that every single extension in the upper limb is 7 and 8. Your wrist flexion is 6, 7, And like we talked about, everything extension wise in the upper limb is 7 and 8. So wrist extension is also 7 and 8. That's really annoying. Your finger flexion and extension is all 7 and 8. And then your abduction and adduction C8 and T1. So if you think about it, starting from your elbow flexion is 5 and 6, your wrist flexion is 6 and 7, and your finger flexion is 7 and 8. So it's like 5, 6, 6, 7, and then 7 and 8, which is a bit easier to remember. And everything extension is 7 and 8. So as long as you remember it kind of sequentially, it makes a lot of sense. Yeah, everyone's like, oh, fuck. In terms of peripheral nerves, there's a lot of peripheral nerves. Not all of them are equally important. I've highlighted the ones that you should remember. Okay, so we talked about how with the long thoracic nerve, that any damage to it can result in a sign called winged scapula, which is when you push your hands against the wall, and then the affected side will have the scapula kind of stick out from your back. Musculocutaneous nerve is basically only important because it's one of those final branches of the brachial plexus. It's not actually that important. The median nerve is actually important. It innervates what's known as the half-loaf group of intrinsic hand muscles in your hand. And it also provides sensation for the lateral 3.5 fingers on the palmar side. Okay, so anytime you hear like, oh, there's been altered sensation in the lateral 3.5 fingers on the palmar side, like you should immediately assume that they've got median nerve injury. Otherwise, any kind of injury to the median nerve will also present with what's called the hand of benediction, which we'll talk about later. Similarly, with the ulnar nerve, it's that other part of the hand that it innervates. So it's the medial 1.5 digits, but it's on both the palmar and the dorsal side. So the median nerve only does the palmar side, but the ulnar nerve does both the palmar and dorsal. Damage to the ulnar nerve, however, presents with the ulnar claw, which also looks very similar to the hand of benediction. We'll talk about that. The axillary nerve, basically the big buzzword for the axillary nerve is the regimental badge, which is like a region of skin over your shoulder. And that's basically all you need to know about the axillary nerve. Radial nerve, damage to it gives you wrist drop. I don't need to talk any more about that. Let's move on. So, an 18-year-old competitive swimmer presents to your clinic complaining of a painful left shoulder. You suspect that he has suffered a rotator cuff tear. What test would you use to identify the muscle most commonly affected? Yeah, good. Seeing some people do like that. Hearing a lot of whispering, but I'm not seeing a lot of hands. God, guys. Okay. Okay, so the answer is the empty can test. Good job, Manoj. Proud of you. So what muscle are you testing with the empty can test? Yeah, so you're testing supraspinatus. Supraspinatus is the most commonly injured rotator cuff muscle. That's actually a really high yield fact, in case you didn't realize. Which is not a branch of the axillary artery. Notice how no one's talking anymore. No takers. C? E. You say C or E? E. Yeah, so what does the costocervical trunk actually branch from then? Good. You don't actually need to know this. This is a pretty low yield. Which of the... I just felt like doing it because I thought the questions were too easy. So which of the below branches from the posterior cord of the brachial plexus? So I'm gonna make the assumption that no one knows the answer then, in which case the correct answer is B, the thoracodorsal nerve. The others will either branch from either the medial or the lateral cords. The thoracodorsal nerve is the only one that actually branches from the posterior cord. That is that cord of the brachial plexus that's posterior to the subclavian artery. So a man presents to the ED following a fall from a ladder. His right upper limb is fixed in an extended and pronated position. Which spinal nerve roots is or are affected? Yes? No? Okay then. A, B, C, did you say? So the answer is actually only A and B. Okay, so what condition does this guy actually have? This guy's got Erb's palsy or Erb-Duchenne palsy. And Erb-Duchenne palsy is only an avulsion of the upper trunk of the brachial plexus, and that's only C5 and 6. So following a fall, a 75-year-old lady comes to the ED with a painful arm. God, there's a lot of ED questions. The following X-ray was obtained. To assess neurovascular preservation, which area of skin is most important? So someone down the front suggested that it was A, the regimental badge area, in which case you'd be correct. It's the regimental badge area. What are you worried about in a surgical neck of humerus fracture? You're mostly worried about either axillary nerve damage or damage to the posterior circumflex artery. Those are the two structures that run around the surgical neck. You do have to learn that. That's really important. So now we're just going to talk about bones, because that's what I love doing. So in terms of your clavicle, the most important thing is, firstly, it keeps your arm away from your thorax, so it increases its range of motion because there's not like a body in the way. It also keeps your arm well suspended and it holds most of the weight. In terms of the actual shape of the clavicle, the medial 2/3 are pretty curved, but then the lateral third is straight. And that has implications on where it's most likely to fracture when you apply force to it. It also protects a bunch of vital structures running underneath it. Your scapula is a funky looking bone. It has a bunch of articulations, and that's all you need to know, really. Your rotator cuff is quite important. It consists of 4 muscles. So one of them is the supraspinatus. You've also got the infraspinatus, teres minor, not major, teres minor, and also subscapularis. And together you just remember that with the acronym SITS. The main role of the rotator cuff is to stabilize your shoulder joint, because your shoulder joint is a ball and socket joint. So there's a lot of freedom. And if you know anything mechanical, you know that anything with a lot of freedom doesn't really have very much stability. So it helps to hold the ball kind of in place. You can also get a bunch of various injuries associated with the rotator cuff. Either you can have like a tear of a muscle, or you can have an impingement of the muscles, and that irritates them and really hurts. Glenohumeral joint is an articulation between your humerus and the glenoid labrum, and it's stabilized by your rotator cuff and a bunch of other stuff. And that's not that important. And there's a bunch of bursas, but you don't really have to know them. The bursas can occasionally inflame, and you can get bursitis, and that's a cause of impingement. And that's really all you should take away from this slide. The axillary spaces is something that people always struggle to learn, but it's actually not that hard if you think about it. We'll start off firstly with the quadrangular space, which is this one here. Okay, so firstly, you've got to know its borders. So its lateral borders the humerus, and its medial borders the long head of the triceps. And then its superior and inferior borders are just teres minor and teres major. In terms of its contents, it holds the posterior circumflex artery and vein, and also holds the axillary nerve. How do you remember that? Well, the posterior circumflex artery and vein and the axillary nerve both wrap around the surgical neck of the humerus. And guess what? The quadrangular space is right next to the surgical neck of humerus. So that's just an easy way for you to remember what structures run through. Triangular space is this one here. And the borders are exactly the same, but you just take away the humerus because it's nowhere near the humerus. And it holds a circumflex scapular artery and vein. This is basically the only time you'll ever hear about the circumflex scapular artery and vein. It's not actually that relevant, aside from the fact that it runs through the triangular space. The interval, lastly, which is this one here, is bordered by the long head of the triceps, the humerus, and teres major. And its contents are the deep brachial artery and the radial nerve. And the reason why that's important is because if you get a shaft of humerus fracture, you risk damage to the deep brachial artery and the radial nerve. Well, guess what? The triangular interval is right next to the shaft of the humerus. So you've just got to associate the structures that run through these spaces with the anatomical location of the humerus that they're running against, and it's a pretty easy way to remember these structures. So the thoracic inlet is also known as the superior thoracic aperture. It's basically bordered by the T1 vertebra, the first rib, and also the manubrium of the sternum. It's not really that important. There's a bunch of structures that run through it, which we'll talk about right now. So coming off the arch of the aorta, you've got the left subclavian and the common carotid artery, and you also have the brachiocephalic trunk. The brachiocephalic trunk then bifurcates into the right common carotid and the right subclavian. When the subclavian artery reaches the lateral border of the first rib, that's when it officially becomes the axillary artery. And it's only at that point that we actually care about it. You don't have to worry about what the subclavian artery does beforehand. In terms of the upper limb anyway, you have to know it for head and neck. Sorry, guys. So it's got 3 parts regarding its relation to pect minor, whether or not it's lateral to it or medial, or if it's underneath. So part 1 is when it's proximal to it, part 2 is when it's deep to it, and then part 3 is when it's distal. The axillary artery also has 6 branches. The way that you remember which branch is associated with which part of the axillary artery is basically that the first part of the axillary artery only has 1 branch, the second part has 2 branches, and then the third part's got 3. So it's easy. So in order, you've got the superior thoracic artery here in the first part. You then got the thoracoacromial trunk, which is this funky looking branch, and also the lateral thoracic, which is this. And both of these are considered part of the second part of the axillary artery. And then you've also got the subscapular artery and the anterior and posterior circumflex, which are these two. And these three are considered part of the third part. If you take the first letter out of all of these arteries, you end up with the fancy little mnemonic 60s teens love sex and pot. And when the axillary artery reaches the lower border of teres major, it basically becomes the brachial artery. And we'll revisit the brachial artery when we go back to the arm. Veins-wise, it's not really that important. It's pretty low yield to learn. I don't think they'll ask you a question on it. But if they do, what happens is that the axillary vein forms at the lower border of teres major, and it forms when the basilic and the brachial veins converge. And you can see that around here. As the axillary vein travels through the upper limb, kind of up, it basically collects a whole bunch of tributaries from all those other deep veins, basically the venous counterpart of all the arteries that we talked about just then. The cephalic vein then drains into the axillary vein just proximal to pect minor. And from there, when it reaches the lateral border of the first rib, it then becomes the subclavian vein. And the subclavian vein then joins with the internal jugular to form the brachiocephalic, and then the two brachiocephalic veins will converge to form the superior vena cava. In terms of lymphatics, you'll have to know this for your OSCEs if they ever make you do a breast exam. I don't think they will, because that's a bit mean, but they totally can. But in general, there are 6 axillary lymph node groups. So this is that thing where you have to feel their armpit, and it's really uncomfortable because it's really sweaty and hot in there. But starting off, you've got the anterior group, which is just behind your pectoralis major. You've got the posterior group, which is in front of your subscapularis muscle. The lateral, which is against the humerus. The central, which is just kind of superficial in the middle of their axilla. The apical is that one where you have to get their arm to drop, and then you reach your hand all the way up into their armpit. And then you've also got the infraclavicular, which is just underneath your clavicle. I always just go for the infraclavicular first, just so I don't forget it, because it's the only one that's not actually in the armpit. So just do that one first so you don't forget. Where do these go? Where do these all drain? Well, they drain into the subclavian lymph trunk. And the subclavian lymph trunk then drains into either the thoracic duct, if you're on the left side, or the right lymphatic duct, which is on the right side. That's basically all you need to know for lymphatics. So now we're going to visit the brachial plexus. Everyone was super scared of it in first year, but no one ever really asked us questions on it in the MST. So I don't really know why people were scared about it. But how do you remember it? So there's roots, trunks, divisions, chords, and branches, and you remember that as remember to drink cold beer, unless you're like me and you don't like beer, because I think beer tastes like shit. How do you remember the branches? So you've got the musculocutaneous, the axillary, and the radial, the median, and then the ulnar. So you have to remember it as musculocutaneous, axillary, radial, because axillary and radial both come off the same posterior cord, median and ulnar. And if you take the first letter of all of these, you get my auntie, rate my uncle. Moving on. So now we're going to actually draw it. They always say that when you're doing your exam, that the first thing you should do is try and draw the brachial plexus, so that way you don't ever have to think about it ever again. Honestly, I don't think they'll ever ask you a question about the brachial plexus, but if they do, here's just the way that I remember how to draw it. So you always start off with 3 arrows, and one of them points in the opposite direction to the other. And then you draw a sideways W, and these are going to be your ultimate, your final 5 branches. So you've got the musculocutaneous, axillary, radial, median, and ulnar. After that, you always draw the long thoracic nerve, because I always forget. And then you draw an X and a /, and those are your divisions. And then after this, what you'll notice is that every single cord gets 3 little peripheral nerves that come off it. And that's basically it. That's your brachial plexus. It's actually not that hard. Does anyone have any questions about that? Oh, great. Moving on then. So in terms of your muscles, your axioappendicular muscles aren't really that important. The only real important one's serratus anterior, because remember, if you damage the long thoracic nerve, it gets paralyzed, and if it gets paralyzed, you get winged scapula. These aren't really that important. That's meant to say levator scapulae, but it's kind of hidden under this. Can I move it? Oh, that's embarrassing. Wise. Your deltoid's important because the skin over the deltoid is also innervated by the nerve that provides motor innervation to the deltoid muscle. That's a really convoluted way of saying that. But basically, the skin over the deltoid is known as the regimental badge. And that's the region of skin that you test if you're assessing for axillary nerve damage. Supraspinatus, like we talked about, is the most commonly injured rotator cuff muscle. And along with infraspinatus, teres minor, and subscapularis, together they form the rotator cuff. You should be learning these proximal and distal attachments, or these origins and insertions, because they do ask you about it in exams. They do ask you about origins and insertions, as annoying as it is. And that's basically it. In terms of clinical anatomy, you can get a condition called thoracic outlet syndrome, which is a bit of a misnomer because thoracic outlet syndrome actually involves the thoracic inlet. So it doesn't really make much sense. It's a compression of structures basically exiting the superior thoracic aperture. Usually the ones affected are either the subclavian venal artery or the brachial plexus. So you can get anything from like neurovascular, like neuropathic pain, like that kind of electric feeling, or you can get things like claudication in your arms. It has a lot of causes. Usually the one that you hear about is what's called a cervical rib. It's when your C8 actually has a rib come off it. It's otherwise a pretty benign condition though. So you can elicit the signs of thoracic outlet syndrome by basically getting someone to abduct their arm all the way to 180 degrees, getting them to turn their head onto the affected side, and then getting them to cough. And apparently that can elicit pain. Erb's palsy, what we were talking about before, is basically when you get an avulsion of the upper trunk of the brachial plexus. So in other words, C5 and C6. Usually it'll be like someone falling down from a height and then smacking the ground between their head and their shoulder. So it increases that angle, and that ends up avulsing the upper trunk. It can also be caused by difficult childbirth. And your arm is basically in what's called the waiter's tip position. So your elbow's extended and pronated. I actually saw a guy with Erb's palsy in Mildura. I don't see an awful lot of Mildura though. Its opposite is Klumpke's palsy, which is unlike Erb's palsy, which is damage to the upper trunk. Klumpke's palsy is damage to the lower trunk of the brachial plexus. So in other words, it's going to be C8 and T1. And it's also caused by difficult childbirth, usually when you're like pulling the baby's arms out. Or if you're falling from a height and you catch onto a branch and it ends up ripping the inferior trunk. And it's basically the opposite of Erb's palsy. So if you remember in Erb's palsy, your elbow is extended and pronated. Well, in Klumpke's palsy, your elbow is flexed and supinated. And if you get enough involvement of T1, you can also end up getting an ipsilateral Horner's syndrome, which is a fun fact. Continuing on, because there's an abrupt change in direction with the kind of alignment of the clavicle in that junction between the middle and the lateral thirds, that's where clavicle fractures will most commonly occur, that junction between the middle and lateral thirds. And how it usually presents is that your arm will droop because it no longer has the clavicle keeping it suspended. And the medial 2/3 of the clavicle get elevated because the sternocleidomastoid no longer has anything kind of stretching it out. Rotator cuff tears usually occur as a result of people overusing it. And the classic example is a swimmer. Like you guys had that PBL in first year about that competitive swimmer who gets a rotator cuff tear and then she like fucks her shoulder up even more because she doesn't listen to her doctor. Yeah. Fucking hate patients. So you can elicit the signs of supraspinatus damage with the empty can test. And that's actually like, you should remember that. That's actually really important. Similarly to a rotator cuff tear, you can also get shoulder impingement or rotator cuff impingement. And that's basically when the muscles in the subacromial space or in your shoulder become irritated. Usually it's because the space in there's been narrowed, either because you've got like osteoarthritis and bony outgrowths, or you've got bursitis where you've got like an irritated bursa. You'll get a decreased range of motion. You'll also get what's called the painful arc, where they can't abduct their arms from 60 to 120 degrees because it really hurts them. But then when you passively abduct their arms up to 120, they can abduct the rest of the way without any pain. You can also elicit it using either Hawkins impingement or Mears sign, which are both tests of impingement. Shoulder dislocations usually occur anteriorly, as opposed to hip dislocations, which usually occur posteriorly. And the only reason for that is because the supports are weaker anteriorly, so it just pops out. You can test it using what's called the shoulder apprehension test, where you like basically try to actually dislocate their shoulder, and you look for the look of apprehension or that look of impending doom on their face as you're about to dislocate their shoulder. Apparently they used to like practice that on people. Like people used to practice that on each other in like clean skills classes, and like someone actually ended up dislocating someone's shoulder. Yeah. So there was a rumor going around where like you don't have to do the shoulder apprehension test because apparently someone actually dislocated the sim patient's shoulder this way, but no, you actually have to do it. You'll do a really good job, like automatically pass your OSCEs if you do that. You can, however, get posterior dislocations, and usually that's got to be with a significant amount of force. So either you've had a seizure or you've been electrocuted. So moving on to the arm. So a boy presents to the ED after falling off the monkey bars at school. His left arm is extremely painful and x-rays of his elbow are shown. What fracture has he suffered? Okay, look, I'm not going to lie, this is actually pretty hard. Anyone want to hazard a guess? Okay, so this is what this is actually showing is a very important X-ray sign, and it's called the anterior sail sign. And well, what's this guy got? This guy's actually got a supracondylar fracture of the humerus. Okay, it's very subtle. You can't actually see where the fracture is, but if you look really closely, you'll notice that there's this translucent triangle here. Can you guys see that? So what that is, that's the anterior fat pad. That usually sits right up against the humerus and you can't see it. But if it's visible, what it means is that there's been an effusion in the joint. Why is there an effusion in the joint? Because there's blood or some kind of fluid. And how do you get that? You get that with a supracondylar fracture of the humerus. So a competitive golf player presents to the GP clinic complaining of elbow pain. You diagnose him with epicondylitis. What movement will be painful? I heard some people say flexion. Yeah, so what does this guy have? Yeah. Yeah, so he's got medial epicondylitis. So what movement will be painful? Someone said C. Yeah, so the answer is C. This guy has medial epicondylitis, also known as golfer's elbow. The reason why I put competitive in parentheses is because no competitive golf player gets golfer's elbow. You've got to be pretty shit to get golfer's elbow. So, moving on to more bones. So, your humerus has got two necks. You've got the anatomical and surgical neck. The one that's clinically relevant is the surgical neck, because when it fractures, you threaten certain structures that run across it, which are these ones that we're talking about, the posterior circumflex artery and the axillary nerve. The radial neck and the deep brachial artery run across what's called the radial groove, which is this diagonal line, okay? And that's also on the midshaft of the humerus. So anytime you get a question about like, oh, this person's got a fracture to the midshaft of the humerus, or this person's got a fracture to the radial groove, it's the same structures that run across. The median nerve and the brachial artery run across the medial supracondylar ridge. And so if someone gets a medial supracondylar ridge fracture, you mostly worry about the median nerve. The ulnar nerve runs posterior to the medial epicondyle. So if you like smack your elbow against a table and you get that like pain that runs down into your hand and you're like, ha ha ha, I hit my funny bone. Get it? Get it? Because it's the humerus. Ha ha. So funny. The medial epicondyle acts as what's called the common flexor attachment for all your forearm muscles. And similarly, the lateral epicondyle acts as what's called the common extensor attachment. So your elbow joint actually consists of 3 joints, and it also has 3 ligaments. The only important ligament that you should know is what's called the annular ligament of the radius, which is this round looking thing here. And what that does is it holds the radial head in place so that it can rotate over the elbow joint. And what that does is it lets your elbow pronate and supinate. So pronation and supination is actually a movement at the elbow rather than at the wrist. And it's only possible because you've got the annular ligament of radius. In terms of vasculature, we are going to repeat ourselves a lot. So the brachial artery runs down your arm and it gives off the deep brachial artery. And guess what? The deep brachial artery runs with the radial nerve along the radial groove of the humerus. Like, holy shit, I had no idea. The brachial artery has a very close association with the median nerve. And guess what? It runs across the medial supracondylar ridge of the humerus. And the brachial artery then, oh wait, this is actually new information. The brachial artery then bifurcates into the radial and the ulnar artery at the cubital fossa. And from there, they'll just run into the forearm. That's basically all that's important. I know this picture's got a lot of like funky looking branches of the artery, but the only important ones that you have to know are the deep brachial artery running in that radial groove and the brachial artery running with the median nerve in the medial supracondylar ridge. In terms of veins, like I said, no one cares about veins. The basilic and cephalic veins ascend from the cubital fossa and they form the axillary vein. Cool. Lymphatics. Yep. Cool. In terms of nerves, though, this is actually important. And guess what? We've literally talked about it 5 minutes ago. Oh, wait, we didn't talk about this. So your posterior arm and most of your posterior upper limb is basically all innervated by the radial nerve. The medial cutaneous nerve of the arm comes from the medial cord of the brachial plexus, and the lateral cutaneous nerve of the arm branches from the radial nerve. So the median nerve travels with the brachial artery and then crosses over, guess what? This medial supracondylar ridge of the humerus. And the radial nerve travels with the deep brachial artery in the midshaft of the humerus. And the ulnar nerve travels posterior to the medial epicondyle. I had a lot of fun making these slides. Muscles-wise, the most important one that you have to remember is that the biceps brachii has 2 heads, a long head and a short head. And when you get a rupture of the tendon of the long head, you end up getting what's called Popeye's deformity. When you get someone who's suffered a rupture of the tendon of the long head to flex their elbow, and then all of a sudden one of their muscles is like huge, and you're like, wow, you've spent too much time by yourself. And the posterior arm muscles, basically, you've only got your triceps and the anconeus. So clinically, Guess what? The surgical neck of the humerus fractures endanger the axillary nerve in the posterior circumflex artery. You've just got to get these anatomical landmarks and the vessels that run across it into your head. Radial groove in the midshaft threatens the radial nerve in the deep brachial artery, and the medial supracondylar ridge endangers the median nerve in the brachial artery. Classic injury that you get with medial supracondylar ridge fractures is like a kid that falls off the monkey bars and then lands on their hand. And they're not always massively displaced, like I showed you on that X-ray. You can always get those very, very subtle signs. And what you have to do is you have to look for those anterior and posterior fat pads. And if they're basically visible, it's known as what's called the anterior or the posterior sail sign. And that's a sign that there's an effusion in the joint. And if there's a kid in pain and you get an X-ray and you get the anterior and posterior sail sign, that's pretty diagnostic of a supracondylar ridge fracture. Medial epicondylitis, also called golfer's elbow, is basically the inflammation of the medial epicondyle. It usually gets caused by poor technique from golfing, and that's the classic injury associated with it. Contrast that with lateral epicondylitis, which usually gets caused by poor technique when you're backhanding in tennis, and that's why it's called tennis elbow. You can also get olecranon bursitis because you've got an olecranon bursa, and that's usually caused by applying too much weight on your elbows. It'll usually be like a student resting their head in their hands on their desk, like crying or something. Now, you can get an injury called radial head subluxation, where the radial head actually subluxes. So it doesn't completely dislocate, but it loses part of its articulation with the annular ligament of the radius. And usually that gets caused by little kids getting pulled by their arm a bit too hard. And how little kids present is that they'll have their arm in like an extended and pronated position, and they really, really, really don't like you moving it because it really hurts. It's a very common kids condition, like I said, and because their arm is extended and pronated, all you have to do is perform that movement in reverse. So all you have to do is flex their elbow and supinate it at the same time, right? You get that? So it's extended and pronated, and what you do to reverse it is flex and supinate. And you have to do it really quickly because if you fuck it up, they're not going to give you a second chance. In fact, like what you have to do, if you do this in the GP clinic, like you have to do it really quickly and you have to run out of the room so that the kid doesn't end up like getting PTSD with doctors. Yeah, it's actually a funny story about this. Like us, there was this little kid who had to get sedated for us to do this to her because like she just wouldn't let us. And then like we saw her again next week in the fracture clinic. And the moment she saw the registrar who did it, she just starts crying. Kids. So, moving on, which is not a content of the cubital fossa. So the answer is the tendon of pronator teres. And the reason why that's the answer is because the pronator teres tendon is actually a border of the cubital fossa. So it can't technically be a content, which is not innervated by the median nerve. So I'm not sure if you guys can read this quickly and like think this through, but the answer basically is the medial head of FDP. What's that innervated by? That's actually innervated by the ulnar nerve. So a man presents to the ED with an injury to his wrist. You find that his hand's in a fixed position where his medial 2 digits are flexed, but he can form a fist. What nerve has been damaged? So the key thing here is that the guy can form a fist, even though he's in a even though he's got like a fixed deformity at rest. So that's a pretty big telltale sign that rather than being a median nerve injury, he's actually got an ulnar nerve injury. So the description is actually of ulnar claw rather than the hand of benediction, because with the hand of benediction, you can't actually form a fist. So radius and ulnar, they both articulate with each other and form proximal and distal radioulnar joints. There's an interosseous membrane that forms between these bones, and the interosseous membrane is incredibly strong to the point where if there's any disruption to the interosseous membrane, you know that the bones have been fractured. The cubital fossa is basically like a concavity in your elbow joint, and it marks the transition from your arm to your forearm. In terms of its borders, you've got the medial border of the brachioradialis as its lateral border, the lateral border of pronator teres as its medial border, the line between, kind of like an imaginary line between the epicondyles as the superior border, and then you've got the floor, which is the brachialis and supinator muscles, and the roof is basically just skin and the median cubital vein. In terms of its contents, you've actually got quite a lot of contents in the cubital fossa. You've got the radial nerve, biceps tendon, the brachial artery, which bifurcates right at the apex into the radial and the ulnar arteries, and also the median nerve. And you remember that as really need beer to be at my nicest, unless you're like me, because I don't like beer. In terms of vasculature, the radial and the ulnar arteries basically just run down the anterior compartment of the forearm. The ulnar artery will give off a branch called the common interosseous artery, which you can see here, and then that bifurcates into the anterior and posterior interosseous arteries, which run on either side of the interosseous membrane. In terms of veins, like I said, no one cares about veins. The only really important thing is that the basilic and the cephalic veins meet for a brief moment at the median cubital vein in the cubital fossa, and then they never see each other again. It's a bit like star-crossed lovers. Lymphatics-wise, nothing's really that important. Again, lymphatics is very, very, very low yield, but the information's here that you can read in your own time. When we get down to the forearm, though, there's only really 3 nerves that are important now because all the others are basically gone. The ulnar nerve travels alongside the ulna and then basically enters the hand through a little compartment called Guyon's canal, which is the space between the hook of the hammock and the pisiform. The radial nerve crosses over the lateral epicondyle, and then it enters the arm through the cubital fossa, and it gives off a little branch called the deep branch of the radial nerve. The deep branch of the radial nerve then gets known as the posterior interosseous nerve, and that innervates the deep muscles of the posterior forearm. The median nerve basically travels down the arm, and then it enters the hand through the carpal tunnel, and that's all you need to know. There's a lot of muscles in the anterior forearm and also the posterior forearm. The easiest way to remember the anterior forearm muscles is you pretend you're like me and you live in Footscray and you're a West Sider, okay? So what you do is you get your other arm and then you put the palm of your hand on your medial epicondyle, and that basically tells you all the anterior superficial forearm muscles. So you've got flexor carpi radialis, pronator teres, you've got palmaris longus, and then you've got flexor digitorum superficialis, which runs underneath palmaris longus, and then flexor carpi ulnaris. And that's basically the easy way of remembering the anterior forearm muscles. In terms of your deep forearm muscle, there's only 3 of them. And the one thing that you have to remember is that flexor digitorum profundus has a dual innervation. So the medial head is innervated by the ulnar nerve, but the lateral head is innervated by the anterior interosseous nerve, which is a branch of the median. And that's all that you really need to know. There's a lot of posterior forearm muscles, but they're not really that important. The only really important ones are abductor pollicis longus, extensor pollicis longus, and extensor pollicis brevis, which all form the borders of the anatomical snuff box in the hand. Clinically, you can get various different injuries when you fall on an outstretched hand, usually depending on how old you are. You can get a buccal fracture of your radius, where one side of your long bone kind of buckles and folds on itself, but your bone's largely intact. There's no actual fracture anywhere, aside from that one little crack, and so you don't do anything for that. You can also get a Colles fracture, where you get a fracture of the distal radius, but it gets dorsally displaced, and so it's also known as the dinner fork deformity because it looks like a dinner fork. Conversely, you also get Smith's fracture, which is when you get a fracture of your distal radius and it gets displaced ventrally. And the difference between Colles and Smith's is basically if you fall on an extended wrist versus falling on a flexed wrist. But who falls on a flexed wrist, honestly? Damage to the median nerve gives you what's called the hand of benediction, where your hand looks normal at rest, but when you try and clench a fist, you end up being unable to flex your lateral 3 digits. So if you try and clench a fist and punch someone, you basically end up just giving them Papa's blessing. Damage to the ulnar nerve gives you what's called ulnar claw, and it's basically the opposite of the hand of benediction. So at rest, okay, you've got this deformity where your medial 2 digits are in flexion, but when you clench a fist, your hand looks completely normal. And I've explained a bit about why that is. It's basically different muscles being paralyzed. But what happens is that if you get damage to your ulnar nerve more proximally, you end up with a completely normal looking hand rather than the ulnar claw. And that's because you paralyze flexor digital and profundus as well. So there's no fixed flexion deformity. And that's known as the ulnar paradox, basically, because the worst damage to the ulnar nerve presents with a less serious sign. If you inflame any muscles, you can get what's called tenosynovitis, where basically the inflammation will spread along the muscle compartment. So you get like this massive line of inflammation that's really painful. And the one that they want you to learn is what's called de Quervain's tenosynovitis, which is basically inflammation of your EPB and APL, so your extensor pollicis brevis and abductor pollicis longus muscles. And usually it's caused by overuse. So usually it'll be like some guys playing on their Xbox or being on their phones. Here's another slide just explaining a bit more that you can read in your own time. And now we're on to the hand. So a 40-year-old lady presents to the GP clinic complaining of a numbness that runs down the palm of her hand. Like, I don't even need to say anything more, and you guys should basically know what the answer is. But she's been taking propofol Uracil for many years. What other relevant signs may you expect? So what has she got firstly? So the most important thing is what this lady's actually got is she's actually got carpal tunnel syndrome. So therefore, she would have none of the above signs. How do you know she's got carpal tunnel syndrome? Well, she's got numbness that runs down the palm of her hand. So there could only be 2 injuries that could occur. Either she's got median nerve injury or ulnar nerve injury. How do you know it's carpal tunnel? Or she's been on propofol Uracil, which is an anti-thyroid medication. So she's probably hypothyroid now. So a man's got pain in his hand following a fall on an outstretched hand. Imaging shows that the carpal bone's being dislocated. Which of the bones below is most likely affected? Does anyone want to hazard a guess? E. It is E. So that's the lunate bone. The key thing is that the carpal bone's being dislocated rather than fractured. If I said that a carpal bone's being fractured, it would be a very different story. So which of these structures does not run through the carpal tunnel? So the answer is B, the tendon of flexocarpi radialis. You should actually learn the structures that run through the carpal tunnel. And let's just move on. So carpal bones, you do actually have to learn them, but it's actually really easy to learn. A first year taught me this. I didn't actually know this, but if you start laterally and kind of go in a clockwise fashion, you basically get the scaphoid, lunate, triquetrum and pisiform, and then you get the hamate, the capitate, the trapezoid, and the trapezium. So if you take all the first letters of all of these, you get straight line to pinky, here comes the thumb. Wow, how wholesome. And just in case you guys didn't know, the carpal bones are at the base of your wrist rather than actually being in your hand. Like I noticed when people were practicing Oskies that they'd be feeling for the carpal bones up here, okay? They're actually at the base of your wrist. So yeah, you can really tell who hasn't been practicing when it comes to the Oskies. So in terms of metacarpals and phalanges, your digits are basically named laterally to medial. So your thumb is the first digit and the pinky is the 5th digit. Every single digit gets a metacarpal. Every single digit gets 3 phalanges, except for your thumb, which only gets 2. And they basically articulate with each other via the MCP joints, the metacarpophalangeal joints. And the phalanges articulate with each other by the interphalangeal joints. So your carpal tunnel is basically a structure that prevents the bowstringing of contents when you flex your wrist. It's what stops your tendons from sticking out when you bend. And its contents are, like I said, the flexor digitorum superficialis and profundus. You've also got flexor pollicis longus, and you've also got the median nerve. And those are basically all the structures. The roof of it is the flexor retinaculum, also called the transverse carpal ligament. It's also the ligament that you cut if you need to perform a carpal tunnel release. The anatomical snuff box is a clinically useful area to test for radial nerve sensation. So it's a concavity on the dorsum of your hand. They call it the anatomical snuff box because apparently people used to put like cocaine there and like snort it or something. The borders are laterally, you've got the abductor pollicis longus and extensor pollicis brevis tendons, and medially you've got extensor pollicis longus. Proximally, you've got the radial styloid, and the floor's basically a bunch of carpal bones, and the roof is basically just skin. Its contents, the most important content is the radial artery and the branches of the radial nerve, but you can also get like the cephalic vein, but like I said, no one cares about the veins. Now the arteries start to do some really funky things here, okay? So firstly, the ulnar artery will enter the hand and then it bifurcates into what's called the superficial and deep palmar arterial arches. The ulnar artery provides the majority of the circulation for the superficial palmar arch. And the superficial arch forms these branches called the common palmar digital arteries, which are these ones in the bright red. The common palmar digital arteries run down the metacarpals and then they bifurcate into the proper palmar digital arteries, which run on either side of your fingers. Your radial artery, however, will also do the same thing, but it provides the majority of the circulation for the deep palmar arterial arch. So the deep palmar arch gives rise to a different bunch of arteries. It gives rise to the palmar metacarpal arteries, which you can't see here, but they provide the blood to the deep structures of the hand. You've also got the princeps pollicis, which runs down the thumb, and then the radialis indicis, which runs down your index finger. In terms of veins, you've got a bunch of veins in your hand, and then out of those veins come the basilic and the cephalic, and that's all I want you to know. Nerves-wise, again, it's pretty important to remember. The median nerve enters the hand via the carpal tunnel, and it provides the motor innervation to a group of intrinsic hand muscles called the half lobe. And that's basically the first 2 lumbricals, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis, and you should remember that. It also provides sensory innervation to the lateral 3.5 digits on the palmar side. The ulnar nerve provides motor innervation to all the other intrinsic hand muscles, and it provides sensory innervation to the medial 1.5 digits on the palmar and dorsal side. The radial nerve is basically everything on the dorsum of your hand, particularly over the anatomical snuff box. So if anyone's got radial nerve injury, the anatomical snuff box is usually the go-to place to test for sensation. So you've got what's called the short hand muscles in your hand. Out of these, the most important ones to remember are the lumbricals. They actually asked us, like, what are the distal attachments of the lumbricals? So I've highlighted that. In terms of your palmar and dorsal interossei, the way you remember it is PAD, so palmar AD ducts, and DAB, so dorsal AB ducts. I'm not going to make a DAB joke. You've also got thenar muscles, which are the muscles in your thenar eminence at the base of your thumb. And the most important thing to remember is adductor pollicis is the only one that's not innervated by the median nerve. So if you get an ulnar nerve injury, you can test for ulnar nerve function through adductor pollicis. Conversely, you've got hypothenar muscles, which are at the base of your pinky finger, and they're not that important, honestly. So onto the last slide. You can get something called carpal tunnel syndrome. Like, did you guys know that? Oh my God. It's basically when the median nerve gets compressed. And like we talk about, you can get signs such as like wasting of the thenar eminence because the muscles aren't being used or stimulated as much. And you also get like a funky pins and needles feeling on the lateral 3.5 digits. Ulnar nerve injury gets tested with Frohman's sign is when you get a piece of paper between their thumb and their index finger and you try and pull it out. And you see whether or not they flex their thumb. If they flex their thumb, it's a sign that their adductor pollicis isn't strong enough. And the only way the adductor pollicis isn't strong enough is because the ulnar nerve's been damaged. Radial nerve injury gives you wrist drop, and it's basically caused by unopposed flexion of the wrist. And you also support that with a loss of sensation in the anatomical snuff box. The boxer's fracture is basically when someone punches with incorrect technique, which is ironic because it's called a boxer's fracture because no boxer would ever get a boxer's fracture. Usually it's when someone's had a few too many tinnies one night and decide to start a fight with a wall. And proper punching technique is basically you want to align your first and second metacarpals with your, why am I teaching guys how to punch people? You align your first and second metacarpals with your radius and ulna. So that way when you punch someone, the force gets evenly distributed. But if you don't punch someone with proper technique and you just punch them with your fist straight on, the force that's applied to your fourth and fifth metacarpals doesn't really travel down your radius and ulna because there's a very kind of sharp angle that the force has to make. So that force just gets distributed just amongst your metacarpals, so you get a fracture of the heads. Your lunate bone can dislocate from falling on an outstretched hand. And most importantly, if you get a fracture of your scaphoid bone and you don't treat it, you get something called avascular necrosis. And that's actually really important to learn because if someone's got pain in their anatomical snuff box and you don't put them in a cast because you take an x-ray and it doesn't look like there's a fracture, if they come back in about 2 weeks, they can have avascular necrosis and their wrist will be in a permanent deformity for the rest of their life. And that's it. Yeah.
Guys, just letting you know, all the food's outside, and the veg GYG is also vegan, so if you have dietary requirements, go for that. Otherwise, go for your life. You weren't as mean as last time.
Me? I like mellowed out.
We got next year.